Hello, everybody. Welcome to Digi4Care podcast. This is our very first episode, and we will introduce this project also with my two guests. The first one is Reka Kovac from the Semmelweis University. Reka, welcome.
Welcome. Thank you for the invitation.
And those who are following our podcast already know Peter Pajitny, who is here third or fourth time. Peter, welcome.
Hello.
Reka,
nice to see you.
Thank you so much. Reka, could you please briefly describe yourself for those who haven't seen and maybe heard about you?
Thank you. My name is Reka Kovac. I've been working in Semmelweis University for 5 years already. And before that, I had a career at the Health Ministry of Hungary, almost 20 years, which is important because of this project as well. And now I work as the coordinator of this project, which we are going to talk about. But I have many other projects in the
So you've been working
University.
20 years for Ministry of Healthcare?
Yes.
That's quite a lot. During that time, maybe 20 ministers in Slovakia has gone and be ministers and didn't. So we are changing that a lot. Petr Pažitný from Vysoká škola ekonomická v Praze, and also those who are following us, he was also the director of Health Policy Institute and the member of the reform team of Rudolf Zayas, the former minister. Have I forget about something?
No, this is as it is. And in English, we say Prague University of Economics and Business. And in Slovak or Czech, Vysoká škola ekonomická. And this was a very nice change that they wanted to stress that the university is in Prague. So that's why the Prague comes as the first in the university name. And I am active in the Czech Republic, Slovakia, Hungary. I studied at the Semmelweis University, and a little bit like 25 years ago already.
So in the past millennium or in this millennium?
Yeah, it was 2001 and 2003, so it's 24 years, yeah. Exactly. So 24 years ago.
Among the first ones who completed our training on health management. I think.
Exactly. So it was, I think, the third class, and there I met Miklos Sočka and Peter Gál, colleagues now of Reka today.
Yes, and how did you guys meet Reka, and how did you find out that you would like to cooperate on the project such as Digi4Care is?
The idea of Digi4Care came from my boss Miklos, who has just been mentioned by Peter, who is the director of our institutions and who started the first healthcare management training in Hungary more than 25 years ago. And our institution started at that time already to be active in the international world as well. But of course, you have to start with little steps. So first we were part of projects. After that, we led work packages, and now we felt us strong enough to coordinate a project. And the idea was that we should collect some good partners around us who we had some connections from other projects or because they were students at our university, and to form a regional project around one of our main topics, which is digitalisation of healthcare.
Thank you so much. Peter, you would have to explain the project in a few sentences. What is Digi4Care, except of what Reka has just mentioned about the digitalization of the healthcare? What is Digi4Care about?
Yeah, this is the project is very complex, and it's Digi4Care, so digitalization of healthcare. But it's not only about digitalization. This is important to say because we are going deeper. And for me, the project and where the project focuses also is so-called integrated care model. That means we are not only promoting digitalization, artificial intelligence, but we are also focusing on how to change the care model and how to integrate even healthcare, social care, and how to change this care model with the help of digitalization. That means in the countries there the healthcare is provided in a certain way, and we try to change how this patient pathway is changing through digitalization. And this is the main goal of the project, how we can change this patient pathway through digitalization in this integrated care model.
You would have to explain again, just briefly, integrated care models, what we are speaking about.
When talking about integrated care models, we have like two views how we can see it. We have a view in terms of only healthcare, meaning we are trying to integrate the care around the patient. That means that the care is not fragmented, but is integrated and has a very good flow how the care is provided within healthcare. And the second, we are trying to integrate health and social. So we are going also beyond healthcare, and we are trying integrating, for example, we have Pilot 4 in Czech Republic, which is about dementia patients. And this is exactly about integrating the healthcare and the social care.
Thank you so much. Digi4Care is also a transnational project which includes 8 countries. Which countries are we speaking about, and how did it happen that there are eight particular countries that you have decided to go with?
And we wanted to build a regional project because there are lots of common challenges in our region, and we saw that we can learn from each other very well in this region. And the program we were applying for is the Danube Region program of Interreg, which includes certain countries you can choose from. And it was also important to have EU countries and non-EU countries in the partnership. And we have now, unfortunately, 7 countries because the Ukrainian partner had to withdraw from the project. But we have from Romania 2 partners, from Slovakia 1 partner, from the Czech Republic 1 partner, from Austria 2 partners, from Hungary 2 partners, from Bulgaria 2 partners, and from Bosnia-Herzegovina 1 partner. So this is how we formed our partnership. And if I can join in a little bit, what was also important for us to choose partners from different areas, from academia, from hospital care institutions, from NGOs, etc., and to kind of build the system level thinking around this topic, because it often we have very good innovations, but we don't know how to integrate them into the pathways, as Peter mentioned, or how to overcome those lots of barriers which are around the use of technology, data, financing, regulation, ethical questions, etc. So we wanted to follow the whole way of integrating a concrete digital technology at a system level. And this is what we are doing in Semmelweis University has Management Training Center, which is our institution, kind of a policy think tank. And we wanted to bring in this thinking into this project.
The common question for both of you, could you stress out something that has all of those 7 countries in common related to maybe challenges that our healthcare systems facing?
I think very inspirational people. And I'm very glad for this project because we found in all of the countries, we found people who really take this as a huge opportunity to move digitalization and to changing the patient pathways. And we know and we learned through the project how this can be complicated in each of the country, and each of the country has very different obstacles or problems we needed to face. And this is what I like personally on this project, is to have this fantastic group of 50 enthusiastic people and really solving like real time problems in the countries, because to run this project, which is really running in these countries, and to put it really into the system is very, very complicated, yeah. And this is especially what I am proud of, that really all these teams were able to pilot the digital or the artificial intelligence or these monitoring solutions in real life situations, and which is, I think, the most important thing, because we can learn. We can do this learning by doing. Yeah, so we are learning because we are doing all of the obstacles and problems we need to overcome. Just one example for all of us. Yeah, so it was, for example, extremely complicated to get the technology, for example, to Bosnia and Herzegovina. Yeah,
Because of the bureaucracy?
because it's not EU country. And so it was very complicated through lots of administration and paperwork to even get the technology to be piloted in Banja Luka. And for us, this is something we already did not see as an obstacle, because we are in EU. So for us, it's not a problem, yeah, when the technology is moving and people are moving. But for them, so this was a real obstacle to get the technology
And
there.
struggle.
Yeah.
Reka, would you add something?
You asked where are the common areas, and there were a lot. I mean, in the challenges. So, for example, regulatory barriers in each country. We have very cumbersome regulations around this area, because nobody knows exactly how to regulate these technologies and the introduction, especially AI, which is a very hot topic everywhere. Yes. Or we had also common challenges with healthcare workforce, that they were very much overloaded, and even they were very enthusiastic in most cases to take part. It was a real challenge to find some of them who could be on board because of the heavy workload, and but many areas we have in common.
Maybe just to add to Reka, yeah. So in pilot 1, we are piloting an AI for digital retinopathy. And for the
Irene, right?
Yeah, Irene for the diabetic retinopathy. And the challenge is that in all 4 countries where the technology is used and piloted, have different model of how they take care about the diabetic patients. That means the biggest example is, for example, in Slovakia, the most of the patients are with the diabetologist. But in other countries, most of the patients are with the general practitioner. So you first needed to understand.
So you'd say that Slovakia is exceptional in that?
Yeah, it's different. Yeah.
Okay.
So I would not say exception. Yeah, because it's different. And first you need to understand how this integrated model is functioning, or how the model of care is functioning in each country, and then you need to put this technology into its correct place. And sometimes it's the diabetologist, sometimes it's the general practitioner, and therefore also then the other steps are then others, and it's different. It's different how you proceed. And now we are in a phase to gathering all these data and synthesizing them, and not even trying to say some recommendations to the country level, but we should be able also to do recommendations that are over the countries, yeah, meaning on some European level, or recommendations that are inter countries. And this is very nice, and this is very thrilling now, that each of the countries doing it a little bit different, because the system is different and the conditions are different, but we need to find some overlapping ideas. Yeah, Reka calls it very nicely. We need to find some horizontal issues. Yeah.
And I guess you have succeeded. Peter, you have already mentioned, or better said, Reka, you have mentioned the AI, and you have also mentioned the regulations. Is it true, or is it like a common sense that basically the regulation is one of the biggest obstacles that are causing that AI is not being used in the healthcare as much as it could be, or maybe as much as it is being used outside the EU region?
I don't know whether this is the biggest obstacle or not, but it is kind of a very new area, and regulations take time, and it is often Europe is often blamed to be slow with innovation because it's overregulation. But if we are talking about healthcare, it is also a patient safety issue. So you just cannot leave AI alone without severe regulation, because it is a very important patient safety. It has complications for patient safety perspective. And this pilot one, actually what has been mentioned by Peter, this is led by our institution. And we really try to understand the 4 countries and the 4 different areas. And we also see that the attitude towards this AI is different within the countries, within the professions. They start to argue on competencies, where to put the competency, because if
The responsibilities maybe as
the
well.
responsibility if the AI says something wrong. And now, for example, in Hungary, we have now the ophthalmologist who can diagnose this and screen this diabetic retinopathy. But from the beginning, we try to carry out the pilot together with them in order to persuade that it is not about taking the responsibility from them and giving it to an AI or even to a GP, but we really have to first check how the AI is working, and we have to find, as Peter mentioned, how we can best solve the screening of this illness in Hungary.
In recent days, I have seen the status of the Czech Ministry of Healthcare, Adam Vojtěch, who has mentioned on Twitter that one of the biggest challenges, or one of the things that he will put pressure on, is digitalization of the healthcare. Peter, if you would have to compare or say something about the digitalization of the healthcare in those countries who are participating, can we say which country is digitalized the most in healthcare?
Yeah, this is a very good question. Like, we have seven countries. I would say now, and please take this as a big picture, yeah, because there are different what can be digitalization, yeah, from apps through technologies, through e-health and recording. So there can be many things that can be called under digitalization. But let's take a very broad picture. I would say there are 2 countries that are the best, and this is Austria and Czech Republic. Yeah, so these are performing out of these 7 the best. But also in other countries, we saw very nice solutions. Yeah, so we just cannot say that this country is not so good. These two are, let's say, the best out of the 7, but we see many very, very nice solution in all of the other countries, and using of AI and digitalization. And maybe it's not always it's a national agenda, but it's an institutional agenda, that there is a strong university or institution that is leading this digitalization or AI. And also one of the goals of this project is to raise up this knowledge and this level, saying, look, these institutions, these universities, these companies are leading in this, and let's try to put this knowledge to a higher level. So make a policy out of it, or make some recommendation out of it. Yeah. So this is also one of the important messages of this project, that we can find lots of very nice examples already now, and put them on a table that look at this, and try to do a digital agenda out of it.
Rika, you would have to answer the question, what is the demand from the healthcare towards digitalization? Because in general, the medicine tends to be conservative for a good reason. Do healthcare professionals, patients, and maybe the organizations that are involved in the healthcare struggle or want to digitalize their healthcare faster, but there are some obstacles?
I think they would like to enhance digitalization. So this was our experience with patients as well. They really did not have big problems with using the different tools, smartwatches, etc., what we use in the project, or even the camera. So they were happy with those digital digital tools, but and also the health professionals were very positive and wanted even more digitalization. In case of health professionals, we often say that they have some fears concerning how the digitalization will take over their work, but it was
They're afraid
not
of that, or
our,
not
it
that?
was not our. So it is a general saying or a general a statement sometimes, but we did not have such experience, so they were very positive. So I think if you involve them and they co-create with them the whole process, where to better place the technology and the competencies and the responsibilities, they are partner in this, because they are overloaded and they really would like to give those administrative and boring and very technical stuff to the AI, which could free some time for them to the real work of healing people. So absolute positive experience what we had in the project, I think.
We are measuring this acceptance. It is called the technology acceptance model. So during these pilots, we are measuring how the patients, clients, and also the staff, the personnel, is accepting the given technology, which is very important. And this methodology is based on the acceptance in the so-called piloting phase. That means we are measuring in real time how these people that are in that real time using this new technology for them are accepting it. And it looks like we have this technology by technology, that there are technologies that are accepted very highly and very good, that are technologies that are, for example, accepted a little bit lower. But again, this is the...
Do we know the reason for that?
The reason can be manifold, because the questionnaire has 15 questions, and we are asking, for example, on how the technology is, for example, easy to use, or how the technology is, for example, make it more efficient their work. Yeah, and these are two contradictory things. Yeah, I make an example. Yeah, for example, in pilot 4, we have a very nice technology for so-called cognitive training, which is a technology that helps people with dementia train the brain. Yeah, so giving them activities that makes them cognitively fit. Yeah. And this technology, for example, is very complex. So, for example, we are measuring there is not so easy to use. Yeah. So the clients like it very much, but they need the personnel that helps them to work with the technology. And when piloting the technology, we had the perception or the assumption that the patients will be doing it by themselves. Yeah? For example, this was not born true, meaning the clients are not able to do the technology by themselves. So the technology is very likable. Clients like it very much. But it really needs the time of the nurse or of the personnel that or the carer that makes the time. So when we are asking about the time efficiency, like this technology is not saving your time as much as we thought, because the person is not able to do it alone, the client. So the technology, they like it. It's a little bit more complicated to use and is not so much time efficient. Yeah, but still, if you ask the people, yes, they would like to have this technology, because it's helping the people with dementia. And what we see there is that the technology provides a very important thing. And this is cognitive training. And the cognitive training is usually done by, let's say, psychologists, or is done by so-called activization nurse. But the technology allows is that also a carer can do it. So you can, from the managerial point of view, you can shift down the competence with this technology. And this is one of the outcomes of the project, that the technology, when even it does not substitute the person, the technology can at least give you the possibility that the high quality training is given to you by a person who has not such a high qualification as before.
Thank you so much. Are there any resistances of the healthcare professionals towards digitalization or using the new tools? Because as Peter has mentioned, sometimes it requires from them comparable amount of time that they are already spending.
Yeah, it's for us also a difficult question. In pilot one, not resistance, but kind of a time-consuming question popped up, because what we are doing now, that we would like to put the screening one level before the ophthalmologist to the GP office, because the ophthalmologists are overburdened, and it would be very nice if they could see only those patients who have already have the result of an examination that they have this retinopathy. But okay, what about GPs? In Hungary, GPs, there are over 50 in average.
It's good for you. In Slovakia, it is much more.
It can
comparing
be
to Slovakia, they are young.
But they are less and less, and we have huge problems of replacing the GPs. So if we say that we would like to get away the burden from the ophthalmologists and we would like to put them on the GPs, then we don't know whether it's the solution, or we have to find out something else, a model how we can insert this screening technology into the Hungarian healthcare system. Because from competence perspective, GPs can very good handle this situation. The technology is there, so the AI with this fundus camera is working very well, but it takes extra 20 minutes per patient to do this screening for the GP, and this is a big question of time.
Yes, of the time, and now we are getting to the motivation. So the GPs might do it, maybe they will want to it, but they has to be motivated somehow. How can we motivate general practitioners to do those stuff? Is there any other way than financing?
Yeah, this is a very good question. And for example, in this pilot one that is piloted in Slovakia, Hungary, Bulgaria, Romania, the technology which is piloted is IRIN from Czech Republic. And in Czech Republic, the General Health Insurance Company, Všeobecná zdravotná poisťovna, they are already financing it. That means there
is full coverage of it.
Yes. So in Czech Republic, approximately 1/3 of all diabetologists, they already have a contract with the health insurance fund, and the health insurance fund is really financing the technology. And there are, I think, 3 or 4 technologies you can buy. So it's the decision of the diabetologist what kind of technology he is buying, or she is buying, because it's a competition in it. And in this case, like this General Health Insurance Fund is showing a very nice example of leadership when leading to the implementation of AI in Czech Republic. And what's more, there are more technologies that are currently financed in Czech Republic from public health insurance. And this is also a case study that what we are working with. That means how can we transform these business models of financing into another countries, because in some countries we see that such like AI or digitalization solutions may not be automatically financed from health insurance funds, and which is absolutely critical for some of them, that there is a smooth implementation, that there is a financing model that allows then in these countries such AI solutions or digital solutions be fully implemented.
Thank you, Reka. Any reactions?
We also were very happy when it was the Peter idea, this technology, this concrete technology, what we are testing in Pilot 1. And one of our main motivations to test it in Hungary was that in the Czech Republic it has already been financed and accepted within the health insurance system. And we really wanted to learn from this example and to adopt it to our circumstances. And yeah, we are still working on it. We are not in the last months of the project yet. But this
yes,
is
the project is being held from 2024 till June 2026, so almost 6 months ahead of us.
We just turned to the last period of the project, so now we are working on evaluating the pilot results, and we are working on all those very interesting health policy, health financing ideas, what we really wanted to include in this system-level project, policy project, because we saw that there are lots of pilots, lots of little nice innovations, but you really have to follow up at system level if you want to have some change in your country. So that is ahead of us now to finish with the strategic thinking, with the strategical proposals for the Danube region, as Peter has already mentioned, that we have to make proposals for regional level, but we have to work on our country level proposals on the basis of our experiences from the pilot, and on our institutional level action plans, how we as institutions gathered within this project will continue with our effort to make our results sustainable.
Understood. Peter, you would have to sum up what are the main outputs of the project, of the whole project, the Digi4Care.
The whole output, or for me the highest value now from the let's say academic or scientific part is that we are really changing the model of care, meaning we are trying to shift how the care for the patient and clients is done today, and we are changing it with technology. So we have there 4 pilots, and with real concrete technology, and now to calculate roughly, there are approximately 15 to 20 technologies in all 4 pilots that are tested. And I think our colleagues will then maybe more in detail discuss these technologies in the later phases of this podcast, and they go then very into the detail. So for me, this is the most important, changing the patient pathway through the technology, piloting it in real-time settings, and learn all the obstacles, because we are very happy for the obstacles, because the obstacle tells you, okay, what we need to do, and create these policy solutions, how to overcome these obstacles.
Are there any obstacles that you didn't count with? That's something that was surprising for you?
Yeah, many. So,
except of the bureaucracy outside the EU.
Yeah, so this is only one, but there are many. For example, there is, I think, when we are talking about digitalization, then or in this project, people are thinking about AI and apps and so on, but sometimes we face the situation that, for example, the Excel knowledge is not so developed. So we need to talk with different, let's say, digital literacy of the workers in healthcare. And this is something that is a complication, because different people have different digital literacy. We are also measuring this digital literacy. And sometimes the knowledge of things we consider as, okay, this is something what should be standard, is not every of these people is managing it. So sometimes we, or for us, the very important thing is that talking about digitalization and talking about AI needs lots of work with the professionals, and therefore we have also these workshops where we on capacity building workshops and sensitization workshops, we try to give some basic information and try to build trust to digitalization and to AI, and also work with some prejudices, that are there, and also we need to count with these different levels of digital literacy.
Understood. Thank you so much. Reka, you and Peter has mentioned that this project is very innovative or wants to be very innovative. In what way?
I think one example could be that our pilots are transnational. So I was part of many European projects which included pilot actions, but those pilots were concentrating on one country, and the results were discussed somehow at the international level. But what we are doing, that there is one technology, one solution, which we are testing in 3 or 4 countries, and we try to do it not in the same way, because it was impossible, but to find a horizontal topic line which is done in every country, and there are add-ons which other countries can do in extra. And this brings up lots of questions from, if you are doing the same pilot, you will see that, for example, the ethical approval of the same pilot, how difficult and different is in from Austria to Bulgaria, or what lots of obstacles can be. So these are those obstacles we did not count with, which comes from the transnationality of these projects. And this is the same with including the people there. How can you involve them? What are the different levels of digital literacy? So I think it was very innovative. Yes, and one important thing I wanted to mention is the data question. How you transfer data nationally, because we are talking about patient data. We had to learn all those difficult terms about pseudonymization and anonymization and aggregation of data, because you just cannot transfer the patient data from Slovakia to us. So we also building...
So that's not possible despite because there is an initiative in the European Union. It's called, I think, EHDS, and it is about data sharing. So it is not allowed that we cannot share the patient data, not even if they are anonymized?
It is difficult. We anonymize them and aggregate them, but we really have to take care of that they cannot be recognized in any way.
So they
even
cannot
if
be
they are
de-anonymized. Okay.
Yeah, because even if you go into very deep details, then you might discover someone if there is only 1 or 2 person in one category between 40 and 50 with diabetes, with this and that, I don't know, data. Mm-hmm. So you really have to take care of this, but it was very difficult to understand each other's circumstances, how the institution is handling data in your country, the concrete institution, what is the country level regulation. So it's a very challenging. We are also building a data management model, which is among our output. So we try to collect the basic experiences of us into this, how you handle data in a transnational way when you are doing pilots together. But we also have very nice deliverables like a toolbox, training materials. We will have a knowledge platform.
And they are public and can be used by anyone, right?
Sorry,
they are public, those toolboxes and data sets.
Everything, all our results will be public, and we will have a knowledge platform where we try to upload not only reports and documents, but we try to make it to be a user-friendly information hub about our experiences.
So it can be adapted by any country, basically we can say in the world.
Yes, hopefully.
Yes. Okay, Peter, you have already mentioned two pilot projects. You've been speaking a little bit about the pilot with dementia, also the pilot with retinopathy and the diabetes. And there are how many pilots are there in total?
Yeah, so there are 4 pilots. In the first pilot is the diabetic retinopathy screening. And the logic is that the screening is not done by the ophthalmologist, but is done either by diabetologist or general practitioner based on the country.
Why not ophthalmologist?
The basic problem definition is that 60% of the diabetic patients who do not have any ophthalmological treatment or recognize the diabetic retinopathy do not go to ophthalmologist. So there is a huge
because
amount.
They don't know that they need to, or there are a lack of ophthalmologists.
Yeah. It's not only one cause. It's more causes. For example, they think it's very complicated to go to the ophthalmologist because it's time consuming, or it's not so much pleasant, or it's not so much consumer oriented, or it's they just don't go. But this group is very big. So let's imagine 60% of these people, and therefore trying to set up a screening to the person which they are in contact like the most, which is the diabetologist or the GP, as in Hungary, makes sense in terms of screening. Yeah. So this is, and the screening itself, Reka mentioned 20 minutes, but it's when the patient is like very complicated. When it's not so much complications, it's maybe between 3 to 5 minutes. So it depends how also the patient is good, like in cooperation, and how the person is skilled. Yeah, so this is also important, how the skill of the person. But it might take you from 3 to maybe 20 minutes. Yeah, but the screening. Compared when, for example, you go to the ophthalmologist, this takes much longer. Yeah, so it does make sense to screen these people in the diabetology or general practitioner level. So this is the pilot 1. And in pilot 1, we have also in Bulgaria, there is one, I think, cardio technology tested, which is also about cardiological prevention. And they have also some AI module that analyzes the data. So this is pilot 1. Then in pilot 2, this is point of care ultrasound, which is I very like, and I'm very unhappy that the Ukrainian partner needed to leave, because that would be exactly for Ukraine a great technology. The logic of the technology is that you have a portable ultrasound, and with portable ultrasound you can go to any place, and a person that is not trained as a doctor or a nurse can do the ultrasound, and a professional, for example, in Vienna, can analyze the picture in real time and can tell you what is happening. So, for example, when there are people in Ukraine, there is the care can be very fragmented or even not there. So you need to have like new models of how for care delivery. So that's a very nice pilot. And there are piloting if this point of care ultrasound in the settings of if the training can be done, for example, on site or online with this point of care ultrasound. Yeah, so this is piloted there. And then in pilot 3, our colleagues are piloting wearable technologies, where they are piloting if you have a wearable technology, then a wearable technology with some notice, and then there is a control group that does not have anything of it, and they are comparing how the patients are compliant and if there is some impact on their health status. So again, a very nice pilot. And then the pilot 4 is, as I said, there is dementia and technologies that are in cognitive training, social robot, movement monitors, and health monitors and others. Yeah, so altogether between 15 to 20 technology in 4 pilots.
And we will have for every pilot we will have a separate podcast that will be introduced after this one.
I hope
is
so.
published. Yes, they will be. Because we can
So
tell a
this is the
secret.
teaser,
Some of them are
Okay.
already recording and
Okay.
cut it and everything. Everything is ready. I'm really a bit obsessed with the question: what will have a patient from it?
What the patient will get.
You'll get, yes.
Good question. Because on the one hand, we are working with a little number of patients because it is not a huge project of.
How many patients are we talking
involving-
about?
It depends on the site.
100?
Around in the whole project, hundreds.
Mm-hmm.
So not like 5,000 or 10,000, which is a study. We are doing feasibility studies in order to examine the bottlenecks, the difficulties, and try to find solutions how to overcome them. But for example, in Hungary, what we hope, and I think this is also in other countries, therefore everyone is working with their stakeholders, that we can really make some change. And we can introduce 1 or 2 of these technologies at system level, and this would mean that the access to these technologies would be for the whole country in the long term, or hopefully not that long term. In our country, for example, there are fundus cameras quite a lot in GP offices. Not that big one, what we are using in this project, but smaller hand variation of these cameras, and perhaps they could be involved in upscaling of this technology to national level. But even if in institution, for example, our partner is the Hungarian National Cardiovascular Institute, which is a huge institute with lots of patients. If, for example, they can scale up this very little project in a couple of years to at least institutional level, this will be also a huge step forward to ensure that more and more patients can benefit from this project and the afterlife of this project. Therefore, we are working on action plans and strategies that.
It was also and that is also my last question. How is this project sustainable after it will end up?
Mm-hmm. From my point of view, the sustainability has a very good potential because all the pilots are aiming on something that is very focused and is doing some real life problem. Yeah. So, for example, the pilot 1 is really dealing with screening the diabetic retinopathy, and the preliminary results see that through this technology we can catch 15% of the population that does not know they have it. Yeah, and diabetic retinopathy, when not treated, can be end in blindness. So now, just imagine that with this technology, we can catch, or we can find those 15% people, which is quite a lot, who does not know they have it. Yeah. So in this screening potential is very high. The same, for example, in pilot 4, where we have this cognitive training, which is very important, and we see that people are liking it, like the patients with cognitive disorders, dementia, they are liking it, and it gives the variability of the training for them. That means the technology is here not to substitute the person, but is helping to provide a very variative training, and which can be even measured. Yeah. So what we did not mention, of course, that all the technologies are very clever, and they can measure the progress of the patients, of the people that are there. So you can use these technologies in a long run to track how the person is improving or what the situation is with the person, which is very important then for the long term, again, also for the sustainability and also for improving the health status of the people.
Reka, thank you for coming. And
Thank
Peter,
you.
also thank you.
Thank
and
you.
we are also inviting you to watch also our next episodes that will be focusing partly on financing, and the remaining podcast will focus on all of the pilots. Thank you. My name was Shimon Lesniak, and yes, thank you.